Moti, you're muted.
Good evening, everyone. You're welcome to another session, another edition of Minds and Beyond webinars. I know that a lot of us have dedicated some special time to be here, and I really want to know where you're calling from tonight. So, wherever you are, whether you're in South Africa, whether you're in Virginia, anywhere, any part of the world that you're in currently, can you put in the chat box? My name is Omotola Ajayi, and I'm one of the co-founders of Minds and Beyond. And you might wonder, what does Minds and Beyond even mean? Maybe you joined from Eventbrite or maybe through somebody's status. Minds and Beyond is a mental health organization that is dedicated to destigmatizing mental health conditions. And we're here to also educate people, answer questions, and hopefully create a safe space where we can pour out our hearts and just talk and have a chat. So you're welcome again. I can see the chat box. I can see the chat box is buzzing. Someone is calling in from York. Thank you for joining Oluwaseun. Grace Adese says England. We're in England. Yes, thank you for joining. I can see that everyone is here and everyone is on board. And I just want to welcome us once again. I'll just hand over to Adebusola. She would introduce herself and we'll take it up from there. Thank you for joining.
Thanks, Omotala. Thank you, everybody, for joining. Good evening, everybody, for joining. Omotala, can you believe that this is our 12th webinar?
It's been 1 year.
Honestly, I want to say a big thank you to everybody for joining today. Today we have such an interesting topic. It's a topic that is really whispered about behind closed door in our culture, and it's just an opportunity to have this conversation in an open space. So I'm really glad that we are all here today. My name is Adebusola Adegbola. I'm a specialty registrar in psychiatry in the United Kingdom. So what essentially means is that what we are talking about today is what I do every day. I am also a spiritual person, so I can talk from the lens of somebody who believes in spirituality and faith, as well as being a psychiatrist. Why are we having today's topic? Today's topic is so important because one of the difficulties we have in our culture is stigma, and stigma allows misunderstanding to continue, and a lot of us have been silent over it because of stigma. But what silence does is that it just worsens the problem. We already know that 1 in 4 person struggle with mental health difficulties. Whether you're here today, you know somebody, a friend, a family. I certainly know people in my inner circle that struggle with mental health difficulties, and I've had mental health challenges myself in my life. So it's not something that is far-fetched. It's something that we need to talk about. So I welcome everybody. We have an amazing guest speaker who is here already. And so we will just start without any further ado, and I will let Omoti read the citation of our guest speaker.
Right. Thank you so much, Adebusola, and welcome everyone once again. Please sit back as you hear this very interesting and amazing biography. Just a short biography, by the way. So I introduce to you, ladies and gentlemen, Dr. Hassan Taiwo Kilani. He's a medical doctor who graduated from the University of Ilorin, Kwara State in Nigeria. He proceeded to the legendary neuropsychiatric hospital Aro Abeokuta in Nigeria for his psychiatry residency between 2017 and 2023. And he became a fellow of the West Africa College of Physicians, in bracket psychiatry, the psychiatry branch. In 2023, like many of us, he moved to the United Kingdom for further training and cross-cultural experience at the Essex Partnership University Trust NHS Foundation. During the fellowship, he acquired multiple certifications and trainings in psychological therapies. During his stint in the UK, he also worked as a community psychiatrist, where he was involved in medical education, various research work, and also mentoring. He has co-authored 2 major global research articles on schizophrenia, which is a major psychotic disorder, one of the things we'll be discussing today. Beyond Dr. Kilani's medical pursuits, he has many years of experience in medical activism and advocacy, from being the editor in chief of the undergraduate campus to being the president of the Association of Resident Doctors in Neuropsychiatric Hospital, Aro, Abeokuta. He is a multi-dimensional creative with many works under his belt, including poems, short stories, and political satires, and two published novels and a biography. He is a mental health advocate and engages in mental health advocacy through story writing and public speaking. He was the Ogun State coordinator and a deputy regional coordinator of the ASIDO Foundation, which is a non governmental association for mental health awareness and advocacy. Currently, he is the pioneer consultant psychiatrist at the Federal University of Technology Akure Teaching Hospital, Ondo State. He has won multiple awards for his meritorious works, including the State Award during the NYSC and also the Provost Merit Award for the Best Resident Doctor of the Year. His interests include being a sport enthusiast, and he's an expert in Korean martial arts, so don't mess with him. He's an expert of taekwondo. He acts, he loves to travel, and he loves to read. Dr. Hassan Kilani is married with three children. Ladies and gentlemen, with a virtual round of applause, with an ovation, I want us to powerfully welcome our guest speaker for today, Dr. Hassan Kilani. You're welcome. Welcome, sir. Thank you for joining and honoring us. You can take over.
Good evening, everyone. I hope you can hear me clearly.
Yes,
I'm
we can
sorry
hear
you might
you.
not be seeing me yet. I'm trying to resolve some technical difficulties. Dr. Adegbola, I've sent the PowerPoint to you. I don't know if you've gotten them. Maybe you'll be the one helping me to move the slides then. Dr. Motola, thank you for your kind introduction. I'm grateful. Hope I can live up to your expectations today. Yeah. So while Dr. Adebola is helping with the uploading,
Hi, Dr.
let me
Kilani.
just start. When I got this topic, it was with mixed feeling actually because of my own interest in the topic myself.
Dr. Kilani, I
Uh,
don't have the slides.
I sent them to you via WhatsApp.
I'm checking my WhatsApp now. I don't have it, sir.
Okay, okay, then.
You can forward it to me as well. That's fine.
Oh, okay. Let me send to both of you. Okay.
Okay, whilst Dr. Kilani is trying to send the slides, I just wanted to see if anyone in the audience has any, before you join a webinar, you probably have like some ideas. You're probably looking forward to certain things, and you really hope maybe someone will touch on those things. So, does anyone want to unmute and just maybe talk about some of their expectations or something that they really wanted clarification on? Or you can put in the chat box as well. We'll definitely address those things at the end. Does anyone want to build the cut? Omola, do you have any questions?
Okay, so I was really interested in the topic
Mm-hmm.
karma, spiritual attack, and psychosis. But more interested in karma. I really want to know that, especially in the place of work or in how we think about things, does karma really exist? Is it something that we we bank on? Sometimes people do things to you, and you really wish there is a way you can maybe not revenge, but let them realize that this is what they did to you is really wrong, or and then you're like, okay, karma will catch up with them. Is it a thing? So yeah, that's what I'm really, really interested in.
Hmm.
Um, yes, sir. That's
Okay. Thank you. Thank you for sharing. Very valid question. I don't want to put the cart before the horse. So I'll let Dr. Kilani do justice to it. But Dr. Kilani, once you're done with the technical issues, please let me know. I'll let Dr. Kilani do justice to it. But
Mhm.
yes, it's very interesting to think that, okay, so this karma that you're hoping happens, is it related to the psychosis as well, because what we're trying to look at is how those three things can interplay. How that sometimes, especially in our culture, they can say that, oh, somebody is experiencing certain mental health difficulties because of some evil that they've done in the past or some bad thing, and it's catching up on them. So this is just very rhetorical. I hope the karma you're, you're referring to doesn't obviously come to mental health. But yeah, it's very interesting. You never know some of these things. There's no wrong or right answer. Busola, do you want to chip in?
Yeah, and I think it's really interesting that she mentioned karma from that perspective. And one of the things I'll be doing here is looking at it from a lot of lens. And I know that Omotola is. I'm sorry if there are other psychiatrists here would agree with me that for some mental health difficulties, for example, depression, somebody who is severely depressed, they truly believe that whatever it is that they are going through is as a result of what they've done, what they've gone through, and we do have a name for it. But
Mhm.
there's that sense of karma in the context of how they are feeling, and they feel that they deserve it. So it is possible to feel that way, even in the context of mental illness. And while you're feeling it is karma, we can certainly see that this thing may, why we believe in spirituality, principalities and powers, and all of that, but we also could see things in the context of this can be mental illness. And we have several examples. And I'm sure that our guest speaker has a lot of examples and may even touch on that as well.
Yeah, absolutely. So it's just it's a lot, and I know that even 1 hour might not be able to do full justice to it. But hopefully, I think another thing that we can do, Dr. Kilani, if you can hear me, is we can start the presentation, and hopefully we can just move on from there. I don't think the slides would be lovely, but I don't think we should take further time now. Dr. Kilani, can you hear me?
I've sent it. It's sent it, and I've
Okay.
with the two of us. So
Okay.
I guess it's fed via email.
Okay, that's fine. That's good.
But it can start definitely.
Yeah. Can you hear?
Yes.
Okay.
Okay. So can I start now?
Yes, please.
Okay, great. So thank you very much for the privilege to discuss this topic today. And like I said previously, it's a topic of significant interest to me because of the environment that I grew up in, and then my religious background, so to say. So I remember very fondly when I told my parents that I was going to be a psychiatrist. And then I remember my dad telling me there was no mad person in our family.
Hmm.
I quipped and I responded and I said, oh, there are. They are just undiagnosed.
Mhm.
And years afterwards, I've come to be proven right, unfortunately so. Now, this is one strength about how we are as a people. And I would like to explain and explore this topic with this outline. I would like to give an introduction, talk a bit about definition of terms, talk about spirituality itself, talk about psychosis and the biomedical etiology, and then explore the link between these two. Are they really mutually exclusive, or is it just about the cognitive framework with which we look at it? And so I will start with the story of the red cap, what I call the tale of the red cap. So about 11 years ago, while I was a medical officer in psychiatry at the State Psychiatry Hospital, Akure, I encountered a lady who was accompanied by her relatives. She was presenting with symptoms of psychosis. She was accusing her husband then of plotting to kill her and that he was going to use her for money rituals. And she was accompanied by the family and the husband. And her family actually also believed that the husband was going to use her for money rituals. But it was evidently a case of schizophrenia. She was admitted and then we managed that. And after 6 weeks, the family pressed for a discharge. So you can go on with the slides, Dr. Adebusala. So the family push for a discharge. So yes, so this is my introduction in which I mentioned that throughout history, every civilization and culture have developed their unique framework to explain and tolerate life inescapable pain and illness. Despite the ultimate shared goal and a certain degree of commonalities, these frameworks have been undeniably shaped by cultural, geographical, and social factors and are varied greatly, ranging from personal and unstructured journeys where individuals seek a connection with a higher power or a purpose, aligning more with spirituality. So you can go to the next slide, please. And this will sum up a lot of what we discussed today. And so the tale of the red cap, which was the patient that kept following me. So I was talking about the woman who had presented with psychosis and was accusing her husband of wanting to use her for money rituals. And her family were also in cahoots with her. They believed that, they shared this belief. Despite our explanation to them that this was psychosis and this was practically something we had analyzed based on a stressful life event as at that time. This lady had 4 daughters. She had no male child. And apart from having 4 daughters, her husband had also come into some money around that time. He had finished their own house and then he was planning to build another house. And in trying to resolve these obviously stressful life events because of the pressure from husband family for him to have another wife, she started having this delusion that the husband was going to kill her and that the money he had gotten to build the house, get other properties, was because he was into money rituals. Eventually, we managed that for 6 weeks and then we discharged her. And I thought that was the last I would say about her. But then, 3 years afterwards, while I was a resident doctor at Neuropsychiatry Hospital at Rabeokuta, I encountered the same lady. She was divorced, now relapsed, and now she was not accusing her husband because they were separated and actually divorced. She was not accusing her father of being a money ritualist. Now, this paints a picture of what you see when spirituality, shared spirituality of a people, influence presentation of symptoms of psychosis and also the treatment. Please, let's move on to the next slide. Now, a bit of some definitions. Now, I'm starting with definition of religion because in a way, religion and spirituality can't be separated. Now, religion has been defined as a group of beliefs and practices and ritualistic behaviors that relate with a transcendent figure or deity in which people have a relationship. In the Western world, it's called God. In Eastern tradition, it could be reality, enlightenment, it could be Buddha, it could be the Hindu gods, but then is an organized form of rituals. You can go to the next slide, please. Whereas spirituality on its own does not necessarily have to go through religion. However, most often they go through religion. And so in our discussion today, we'll be talking about religion somewhat. Because in spirituality, you might find someone that is an atheist actually saying they are spiritual, despite the fact that people would often say, oh, spirituality has to do with a relationship with an higher being, a figure who is transcendental. However, we found a concept called the the spiritual atheist, in which even atheists now advocate the fact that they are spiritual in their own way. And we've seen situations whereby people who are into substance use will tell you they are spiritual because, in quote, of the spirit in the bottle. Now, let's go to the next slide, Dr. Adebusola. Now, the difference between spirituality is just what I had explained initially about the fact that religion and spirituality are two intertwined concepts in which you can hardly separate them, even though religion seems to be organized, whereas spirituality could be private and not public or not communal. There's the next slide. Now, let's talk a bit about psychosis before we then explore more about spirituality. Psychosis originates from the Greek word psych for the mind, and then the abnormality of the mind, the osis. And before the 1980, the concept of psychosis had to do with someone that was not functioning mentally and optimally in terms of their mental functioning. However, with the advent of the DSM-3 in 1980, it was used to describe a gross impairment in reality testing, which basically means inability to distinguish between one's internal experience of the mind and then the external reality of the environment. However, in 1994, with the advent of the DSM-4, it then became specifically used to describe a mental disorder characterized by delusion, which we know as a fixed belief or false belief back in the days. Although we now know that a delusion might not actually be a false belief. And I'll give an example. A man could be having a delusion that their wife is having an extramarital affair, and then in truth, they could actually be having the extramarital affair, but it's still a delusion because the way the man came around to have that belief was without evidence. It was so for an alcoholic, which is something that is common among alcoholics. An alcoholic could have a strong belief that their wife, their spouse, actually has extramarital affairs because the man ab initio is giving a lot of time to alcoholism and then believes that if she's not getting it from me, she must be getting it from somewhere else. And so is deluded in that way. Another symptom that was used to describe psychosis in DSM-4 is hallucination, in which an individual has perceptual disturbances in all the five senses, either the visual, where they see things that other people do not see in clear consciousness, or they hear voices that other people do not hear in clear consciousness, or they smell odors that other people do not perceive in clear consciousness, or they feel touch or movement around their body, or they perceive taste on their tongue that other people do not perceive. Now, the other symptoms that is characteristic of psychosis is disorganized thoughts, and this will manifest in the speech of the individual. So you see an individual who is talking incoherently, an individual who is saying words, neologism, making up words, attributing new meanings to words. So an individual could say something like, mojo, and then you ask him what does mojo mean, and they tell you that, oh, it means someone that is powerful. And then you can't find this in any dictionary or any language that is spoken around where that person lives. And it could just be something nonsensical. It could just be word salad, and it could be somebody repeating words over and over again. And it could be the most obvious one that we see often, which is abnormal behavior, in which people start behaving out of sync. They could have bizarre postures, they could be taking off their clothes, they could be doing things that in looking at the community is abnormal, something that you would not expect for anyone in the normal senses in quotes to exhibit. The next slide, Dr. Adebusola. Now, with the DSM-5, it was then more structured, in which there were now discussion about clinical syndromes. And this is where we'll go into the classification of the psychotic disorders like schizophrenia, like delusional disorders, like schizoaffective disorders. And then with the next slide, I think we'll talk about the symptomatology of this. Please, the next slide. As we know with schizophrenia, I hope you can see this slide. It's a bit tiny. Schizophrenia, we know the hallmark of the symptoms are delusion, hallucinations, disorganized behavior. And with the DSM-5, this will have been persistent for about 6 months. And basically, the treatment is with antipsychotics biomedically, and then the psychosocial treatment, in which the individual, after they've been stabilized, will then have intervention from the psychologist. And also, if there were some social stressors that had predicted at the onset of the psychosis, that would then be addressed. Then we have schizoaffective disorder from the name schizo, which would be someone that has psychotic symptoms, things like delusion, hallucination, now also experiencing affective or mood symptoms. So you see this individual could be having hearing voices of unseen persons, and also be having an elevated mood symptoms like believing are the greatest person in the world, laughing excessively, or this person could be depressed. So it could be either a low mood or excessively elevated mood alongside psychotic symptoms. We also have delusional disorder in which you see an individual basically having beliefs that are not congruent with their educational background and their social status. So let me give an example. An example could be someone who is a professor of medicine, now all of a sudden are believing that he has HIV, despite having done multiple tests that came back to be negative. Now, looking at the background of this individual, this person is a professor of medicine or hematology, whom you expect should have knowledge of this. And now this individual now believes they have HIV despite having evidence to the contrary. This is what you see basically in delusional disorder. Unlike in schizophrenia, where you have delusions and you also have hallucinations alongside and other behaviors. Then we also have depressive disorder that could occur alongside psychotic symptoms. Unlike in schizoaffective disorder, where you see both of them are occurring with the same intensity and about the same time. So in depression with psychosis, the depression will be most often the bigger picture, but then alongside psychotic symptoms. And then we have brief psychotic disorder in which there is a limited duration for these symptoms. And then the postpartum psychotic disorder, which occurs in women after they've delivered their babies around that postpartum period. And a lot of reasons have been adduced to cause this, including the social support the pregnant woman had gotten while they were pregnant, the hormonal imbalance that occurs with pregnancy and subsequent delivery, and other psychosocial factors that could occur. And with the treatment of these psychotic disorders, like I said, is biopsychosocial, in which the treatment occurs with medication and also resolving the psychosocial issue, which could come with occupation, it could come with relationship, it could come with dealing with politics in the society, to come with insecurity, to come with a lot of psychosocial stressors that we see. Please, the next slide, Dr. Adebusola. Now, these are classifications, other classifications that we have of psychotic disorders. Even though the bulk of the psychotic disorders are things that we might not be able to lay our fingers on the exact cause, but then we know there are some of them that you can identify the exact cause, like drug-induced psychotic disorder, in which an individual take illicit substances like cannabis, like PCP, ecstasy, and then they start manifesting psychotic symptoms like having paranoia resulting into delusion, having hallucination, and it could also be because people have taken medications that might be prescribed, but then these medications are now taken excessively. It could also be as a result of organic conditions, in which physical health conditions like hypertension, like even malaria fever has been seen. Fever itself could cause psychotic symptoms in people who are predisposed. So physical conditions, space occupying lesions like cancer in the head, could also present with psychotic symptoms. Please, the next slide, Dr. Adebusola. Now, still talking about the etiology of psychosis, and this is one of the places where you see the non-psychiatrists differing with psychiatrists, and then they will tell us, we talk about evidence-based psychiatry. However, they will tell us, we say something today, we talk about having definitive answers to questions, but then by tomorrow we'll say we've gotten more information. And then they feel like psychiatrists are not exact, that we don't have an exact science. So we talk about models. So we have models of etiology of psychosis. And the one that had been very much around at the beginning is what is called the neurodegenerative model. So this model has to do with the fact that in the beginning, the thought was that psychosis was as a result of degeneration in the brain, in which, just like what happens in dementia, that is a progressive disease that would not improve no matter what you do. However, this subsequently was rejected because we got more information with more research. And then came the neurodevelopmental model, which is what has also been around for more time. And we talk about the silent lesion. And this basically means that the brain of a child, when a child is born, there is some sort of insult, a sort of deficiency in the brain. And now this deficiency, as at that time, would not manifest because the growing brain is not being taxed with challenging function as at that time. However, when this individual grows up to adolescent or young adulthood, and then the brain starts integrating, now the deficit that was in the growing brain now start manifesting as the abnormal behavior that we would see. And now these challenges could be education, it could be marriage, it could be somebody being having traumatic experience like a rape, it could be anything that could trigger. And because the brain had been in a way damaged at the beginning, however, the damage was not bad enough to disturb the growing brain to function. However, when the brain is now challenged with more stressful life event, then you see the individual start exhibiting psychotic symptoms. Now, these stressors could be something from genetic.
Have I lost them?
Yes.
And now this has to do with the fact
Yes,
that,
please.
okay, I'm not seeing the slide anymore. So now the developmental risk model has to do with the fact that rather than talk about just the brain as when the child is growing, causing psychosis, we're not talking about the fact that a lot of the insults that occur leading to psychosis are not just what happens when the child is growing. No, that there are things that happen when the child is growing like an adult. So like an adult, you see an adult take alcohol, smokes, develop hypertension, diabetes. You see an adult having a toxic relationship. Now, so it is said that all of those risk factors. So now, don't let's just talk about neurodevelopmental. Don't let's talk about the fact that, oh, there were insults to the brain as a child. Let's talk about the fact that while we're growing up as adults, we encounter a lot of stress source. Moving to the moving abroad, moving to the US, moving to the UK, getting married, urban migration, all of those things, they are risk factors. As much as one has these risk factors, the more the risk factors, the greater the tendency of the individual then coming down with psychosis. Now, that's the current model for explaining psychosis. Please, the next slide, Dr. Adebusele. Now, this is just a picture showing, explaining the factors that could actually predispose one to having psychotic disorder. You can see that genetic predisposition is very, very significant. And it is said that genetics is like what lays the foundation for the other insults to come. And that's why family history is very significant in people that will eventually develop psychosis, because genetics will have increased the vulnerability of the individual to either come down with psychosis or have resilience that could weather the storms of psychosis. The other things are those things we've talked about developmental pathway, the drug-induced psychosis pathway, and then for postpartum psychosis, the hormonal imbalance, and then for women, the dynamic of hormonal imbalance occurs both at menarche and also during the period of menopause. All of this could predispose to an individual now coming down with psychosis. Please, the next slide. Yeah, so now this is the final common pathway. So with all of the hypotheses we've talked about, there are still more hypotheses, but the most popular of them is the dopaminergic hypothesis, which means dopamine, as we know, is the feel-good neurotransmitter in which when an individual eats, when we drink water, when we have sex, that is the hormone that is associated with all of these good reward. However, that's not the only thing it does in our brain. Dopamine also has been found to be excessive and in some cases very, very deficient in the production of psychotic symptoms. Symptoms that are called positive symptoms like delusion, like hallucination, which are called positive symptoms because they are excessive. They are supposed to be there, but then they are not excessive. So like hearing voices, we are supposed to hear voices. However, when it's excessive or abnormal, that is positive symptoms. So these are reported to be caused by the excessive dopamine in the brain. Whereas when there is deficient dopamine in the brain, we see signs like negative symptoms like an individual not being able to talk, an individual not responding well. All of these are what we see with dopamine. However, how does dopamine then translate to these symptoms? So let's go to the next slide so that I can explain how dopamine then gets to give individual those symptoms. And this is what we call the prediction error or salience theory. Now, prediction error has to do with the fact that when we learn from prediction error. So what we expect, we predict what will happen in our environment. However, if those predictions do not match our reality, we are surprised. Now, when we're surprised, this translates to an increase in the dopamine. Now, this is how we learn. So the brain then adjusts and says, because today I expected that the rain was going to fall, it didn't fall. And then the next time, the brain now adjusts and say, oh, the rain might not fall on this day. It doesn't fall on a Monday, it falls on Tuesday. Then you learn that. Now, this is now in relation to what we call the salience theory. Now, the salience theory has to do with the fact that the relevance that our brain then gives to events. So normally, our brain is supposed to give importance to only events that are relevant. However, when there's prediction error and in psychosis, you now see the brain, because the dopamine is now excessive, leading to a lot of prediction error. So what now happens is that rather than the brain seeing otherwise harmless events, the brain then starts interpreting these harmless events, the harmless events as events that are very, very fearful. And so an example is somebody passes by, a car passes by, a car that is red in color, and then the individual starts thinking, oh, what that means is that somebody is going to die in our house today. Now, this is what would happen if someone is having a salient abnormality of the salience theory. Because now the brain is seeing things that should not be connected and is connecting them abnormally. The next slide, please, Dr. Ibisola. Now, this is how psychosis actually manifests in individual. Now, I want us to now
Dr.
explore a
Kilani.
bit about spirituality.
Dr. Kilani.
Yes, yes,
Sorry
please.
to interrupt you. I'm so sorry to interrupt you.
Yes,
So I
please.
just wanted to, just because we're careful with the time, and we know
Yes,
that
please.
obviously there's some questions that might want to pop up, and we also just wanted to kind of make it a little more interactive. So I just wanted
Yes,
to
please.
find out, just based off on the beautiful presentation that you've done so far, it's been so eye-opening. I just wanted to find out, I have a question. So
Yes,
with all of these things that you explained a lot of science behind psychosis. Yes, you've also talked about some of the social factors, some other factors, developmental factors. But why is it that when, especially in our climate, when most people have psychosis, the themes are usually religious. It's always something spiritual, like, oh, my enemies are after me, or someone is being diabolical. What explains that? Because if, for
yes,
me, obviously, as I'm asking this question, you know that I know the answer, right? But
yes,
in terms of like our audience, I'm sure some of them would feel like, oh, these things, I mean, it's not normal. I mean, if you are Yoruba, you might say it's in quotes, Ishaye, that's the works
yes,
of people of the world or diabolical things. Yeah.
yes.
So are you able to just break it down for us? Like why does that happen in the first place?
Yes. So this has to do a lot with culture and spirituality. And thankfully, even though I'm going to be exploring the other spirituality, thankfully I had explored the African traditional religion, which was what I did with the Tale of the Red Cap. So in African traditional religion, there's actually karma. There's karma in African traditional religion. And that's why the topic is very succinct, because karma permeates almost all spirituality. So in African traditional means, it is believed that one, spiritual affliction causes psychosis. Secondly, it is believed that it's a reprisal, that when people do evil, that they are visited by the deeds that they've done with the law of karma, and that they then come down with psychosis. And like Freud, in his book, what we call the future of illusion, when he was talking about religion, he actually explained the fact that religion is a way by which we explain our pains when we do not have alternative explanation for them, which is what we do because we do not have those alternative explanation, and it is easier for us to go with what our religious and spiritual leaders have told us, because that way it's more egosyntonic. What I mean by that is that it goes more with what we've always known, and
Mm-hmm.
no matter how bad it is, because it's what we have always believed, it's easier for us to just go with that rather than bringing new knowledge. However, there is now a transition because people are now developing in culture, people are migrating, people are getting more educated, and then there's now more information. So you see an individual who believes in spiritual attack still taking their client to the hospital for treatment.
Mm-hmm.
So that's where we are now. So we now have a match of both of them now. But then I'm
Okay.
going to explore the other spirituality as we go along.
Yeah, we might not be going along because of the time, Dr. Kilani, unfortunately.
Okay,
But I just had more questions. So
okay,
you
please.
from the what you said now, you said obviously the traditional religion believes in karma. We had an initial question from Omolola, one of the audience members of the audience. She asked whether karma actually exists. Is it possible? Like, does karma actually exist? I mean, I don't know if it's a yes or no answer, but I think she was very
Okay,
curious about it. And that's one part of the question. The second part is what I'm adding now is, what if I don't believe in karma? So does that still explain, like, a lot of people can believe in karma, but what if I don't believe in karma, or someone doesn't believe in karma and then they still end up having psychosis? How can we
I mean,
further simplify that for our audience tonight?
okay. So first, the fact that karma exists or not is not a yes or no answer. It has to do with the individual who believes in karma. So it's a cognitive framework. So it's the same thing that happens when an individual believes is going to be able to do something. So it's a cognitive framework. So it's the way our mind works. And that's what religion is about. So one of the typical examples is the fact that if any one of us was born a Muslim and our parents brought us up in that way, we are likely going to grow up defending that religion. If someone also was born a Christian, that person is likely going to grow up believing that. And whatever they do, even though they strive, they are going to be supporting all of those things with that belief system. So karma is a myth that is a belief system. So what we do as practitioners most of the time is we don't challenge the belief. What we do is we work with that belief that the individual has. So when you work with that belief, because this is the framework that this person believes in, so you have to work with that belief. Whatever happens to them will be explained with that belief that they have. So it's not about it being a yes or being a no. It's about the fact that if anyone believes in karma, whatever they do will be along that. And it's not just something that is African. If you look at most Hollywood movies that we watch, a lot of these movies at the end of the day are always ending up with the protagonist defeating the villain, no matter how strong the villain is. Now that works for us. The same thing with karma. Now, karma can be the one that will be the stressor that will lead to the illness. It could also be what will help with coming out of it. And let me explain. So with karma, so an individual that believes that he has done evil, maybe a man who cheated on their wife, because they believe they've done evil and they believe karma will be visited upon them. Now, this will lead to stressful thoughts in their mind. And then if this person was already predisposed to having a mental illness or psychosis, the tendency then would be that because of this belief that they have that there's karma, the tendency is that the individual would likely then break down and then will now start forming delusions that will now be like, it could be having delusions that the wife wants to kill him just because he believed there's karma. That was the framework initially that they had. Now, because of this framework they had, they believe so their thought pattern will be inclined towards that. Now, if this individual, now because of the precision error that they now have, because of the karma that they had, then the individual could now start hearing the voice of their wife, telling them they are going to die. Now, this is because ab initio they believed in karma. However, someone that does not believe in karma will most likely not come down with psychosis based on that. So that's the concept of psychosis and karma. Now, give an example. If someone is an American, if they're going to have a delusion, a sign of psychosis, it's likely going to be that CIA is chasing them, rather than an African who have a belief that somebody is attacking them spiritually. Now, so that is the framework. So karma has to do with framework. Most spirituality, most religious concept come with that. Buddhism believes in karma. Hinduism believes in karma. Except Scientology, which is the religion that has to do with engram, with auditing, purifying what they feel is a part of the component of the body. With Scientology, Scientology is a spirituality concept that is controversial in a lot of ways. And the reason is because even though it is called a church, Scientology was actually vetted by someone that has a lot of background in psychology. It was even someone that was actually managed for psychosis before. And he was an engineer. And so with him, the concept for people that are in the church of Scientology is not that there is karma. So when they have psychosis, they believe that it is caused by engram, it is caused by some impurity. And what they do is what is called auditing, in which they try to purify all of these. So you can see where the framework differs. So with the Abrahamic religion like Christianity, Islam, Hinduism, which is not Abrahamic, but Buddhism actually came from Hinduism. So with Hinduism, with Buddhism, and with the Abrahamic religion, karma exists because that is what actually potentiates those religions. Because those religions have a superior deity, which they believe that if you do bad, you eventually go to a place that is bad. If you do good, you go to a place that is good. And so karma has to explain that concept. And that's what actually perpetuates the religious belief. And that's why karma would be in those spirituality. However, with the Church of Scientology, which is what is a bit closer to what we find with atheists or with the Freudian class, they do not believe in karma because they do not actually believe in that concept. So what they believe is that is the component of the mind that is impure and that has to be audited. So the word is called audit, in which they purify that. And they do not use antipsychotics. They do not use antipsychotics at all. They're actually one of those people that are called anti-psychiatry because they do not believe in that concept. So karma has to do with that concept that supports spirituality, that when you do bad, you'll be rewarded for bad. When you do good, you'll be rewarded for good. So basically, that's why psychosis is explained in that context. However, there's now a change. So there's a drive because of migration. So you see an Asian Muslim who now lives in the West. So you see an African Muslim who now lives in the US. And so because of this adulteration of culture, you now have someone that, even though they believe in spiritual attacks, so you see a Christian who will pray and then use their antipsychotics. So you see a Muslim who will do ruqya. So ruqya is one of the ways that Muslims treat psychosis, because the Muslim believe that genes can afflict people with psychosis. They also believe that psychosis could be caused when people are taking what is called usury, which is when people take interest on money. So that's also an example of the law of karma. So in Islam, it is believed that when you do things that are against the dictate of the religion, there will be repercussion for what you have done. And so a Muslim will believe that if you engage in usury, maybe you go to the bank, you get a loan, you get usury, or someone takes alcohol, then the repercussion will be, or you take cannabis. So that is in. And so rukia is something that is now used to treat. That is exorcism, which is something we find in Christianity. So in
Yeah.
Christianity, that's the same thing. So you can see that the law of karma permeates both Abrahamic religion, Christianity
Yeah.
and Islam, and it also permeates Hinduism and Buddhism, which are the Eastern spirituality. That the only one that is different is the Church of Scientology, and also for the atheists. And then the Freudian do not even believe in religion. They believe religion is something that was developed by man after man had failed in conquering culture. They believe that man has to be tamed by force, and that because that, unlike in the olden days when with force you could make sure that people obey a leader, and by obeying a leader you can bring people together to make civilization occur. However, when that not be substantiated, then religion came up, and so a powerful man would then start preaching what they believe in. And this powerful man will be someone that is charismatic, someone that has had control of their libidinal desire, like love for sex, love for cannibalism, love for incest. Now, this man, like in Islam, would be Prophet Muhammad, like in Christianity, would be Jesus. They will now be the one now preaching to people in a way of controlling them. So they will now be the ones that will work with things like karma.
Okay, thank you so much, Dr. Kenani. Yes, that was very extensive. I believe that we've all learned one or two things. So thank you. I think essentially it depends on what you believe. So your belief system definitely informs some of the symptoms that one would exhibit when they have psychosis. So thank you for the extensive explanation.
Absolutely, Dr. Kilade. I think you're just so knowledgeable in this area, and you're just the best person to have talked to us about this topic. I'm just going to do a little bit of summary and then raise some of the questions in the chat with you, just so that I can break it down a little bit in simple terms. So you've shared a lot of things with us today. You've described what psychosis is, and you've said that psychosis is when there is absence or the loss of reality, when what somebody is experiencing, be it seeing things, hearing voices, feeling things crawling on them, or having some thought and beliefs and experiences, but it's not in keeping with what's going on in reality. And you've talked to us about so many causes, things that can cause psychosis, from whether it is drug to experiences, to changes in the chemicals in the brain, to having it in the family, and everything that could result in it. And you've also mentioned the karma being the concept of good or bad and the belief, and that for somebody to have this karma experience to result in psychosis, there is a very high probability that a person already is at a risk of having one form of mental illness or the other. We have a question in the chat that says, is hallucination the same thing as premonition? Just because I know that you want to explain everything together, I'm just going to ask the second one together as well. That what of deja vu? Is deja
So I didn't get the first one, please.
The first one is
hallucination the same thing as what?
As premonition. I was kind of attempting to find hallucination, but I felt, let me leave it to you. And then the second one is, what of deja vu? Is deja vu a sign of psychosis? I want you to quickly answer those questions so that we can now move to pathway of care, because our belief, our religion, our culture also shapes the pathway of care, and it will do ourselves a disservice if we don't talk about pathway to care here.
Yeah, thank you. So hallucination is not premonition. No. So hallucination is, so the easy way to explain is that we have 5 senses. We have the sense of sight, the sense of hearing, the sense of touch, the sense of smell. Now, hallucination occurs when there is abnormality with the function of those senses. So auditory hallucination would be that we are expected to hear voices when people talk. In a situation where we then hear voices when there's no one talking, and we are in clear consciousness, so it's not like we're sleeping, we are very conscious, and then we can hear voices, that would be hallucination. Now, if we can see things when there's no one there, and the people around us cannot see those things. Now, that will be visual hallucination. That is hallucination. Now, premonition is like when you have a sense of something about to happen, something a bit similar to what some people might call deja vu, in which you have some sense that something might happen. For some people that are in the business of espionage, it could be something that they've been trained for. So you just have a sense something might happen. It even occurs for people that are clinicians. You just have a sense of something. That will be premonition, like something wants to happen. But hallucination is an abnormality in the perception of senses. So like hearing, seeing, or taste or odor. So you are perceiving an odor that other people around you do not perceive. I don't know if that explains it to the questioner, please.
I believe so. I think that was very clear. It's just basically having sensations or feelings or perceptions in all our five senses, like you've explained. So thank you so much for differentiating. How about the second question? He said, what about deja vu?
Oh, I didn't even know that was the second question, but
He
that
said,
was something I
what
said.
of deja vu? Is he a sign of psychosis? I love that. I think you should just please help us clump it with other normal phenomenon that can overlap. I think that would be a nice way to answer the question.
So deja vu is when you feel like, oh, I've been here before. So that is deja vu. Now I'm trying so hard now to remember the second one that I know Dr. Amotola was referring to. So deja vu is when you feel like, oh, I've been here before. You feel like something that is happening to you has happened before. Now, that thing had not happened before, but you just have a feeling. So it's like what we call like a sort of sometimes an airy feeling. So you just feel like, oh, this thing had happened to me. I've been here before. I can see the environment. I know this environment, but you've not been there before. So that is deja vu. It's not psychosis. No, it is not. It is not psychosis. Those are things like depersonalization, in which you just feel like, oh, the environment is transiently somehow not real, but then you snap out of it after a while. Whereas in psychosis,
okay.
Yes, please.
Sorry, Dr. Killen. I just wanted to find out because sometimes, even in psychosis, they could have those kind of experiences, either deja vu or jamais vu. You feel like, oh, this has never happened before. Meanwhile, it has happened. So
Yes.
I just wanted to find out if, when do we begin to think it's psychosis, or when do we just let it be and just say, oh, this is normal?
Okay, so now is deja vu. If you get there, it's transient. However, when you now have the cause symptoms, so you have someone having a strong belief, despite having evidence to the contrary, that something is going to happen to them, and other people around them do not believe this, and they give counter evidence, and this person holds on to what they believe in, and it's been occurring for at least a month, and then it's not affecting their functioning. And this is very important. So this is one of the, when people ask me, oh, people hear voices that are pastors, malams hear voices, do you say they are psychotic? No. Now psychosis occurs when there is now a deviation in functioning. So this behavior that this person is exhibiting, or these symptoms, is not affecting how they function, it's affecting their relationship. And when we talk about function, we're talking about function in 4 different domains. Personal functioning, in which this person cannot sleep, cannot eat, the hygiene is affected. It could be functioning in interpersonal, which is has to do with relationship with people around them. It could be functioning in terms of family. So a father cannot function as a father again. A husband cannot fulfill their role. A student cannot fulfill their role as a student. And then it could now be communal, in which this person is not having challenges with people in the society. So when those symptoms is persistent and it's not affecting your functioning, that's when we then call it a psychotic or a mental health symptoms, so to say. However, if it's just something transient, everybody has these feelings. Everybody, one time or the other, will have this feeling. When you are stressed, especially when you are stressed, you have these feelings occurring when you are stressed.
Mm.
Yeah, absolutely. And there's always sometimes an overlap even with spiritual experiences. So, for example, people that have, fasted for a long time, or when
Yes.
you're just in a solitary place, you might begin to think that, oh, did I just see a shadow? Did I just do this? So, yeah, so those things can happen. But just like you said, sir, once it is not consistent and it's not affecting functioning, then we can breathe and say, okay, I think things are going on well. So just because obviously we have a mixed audience today, we're just wondering what your final words would be in terms of, okay, I see someone, normally, oh, I know someone that is experiencing so and so and so. When should I seek help? How can I seek help? Especially for people, you could speak to both audiences, both diaspora and Nigeria, but I think Nigeria would be a more, they would benefit from that. How can they seek help? When should they seek help?
Okay. So thank you very much for this question. And this is something I think is very important for the audience to take away today. So when there is a deviation in an individual's behavior, this deviation would be noticed by people around them. When that deviation becomes persistent, when that behavior becomes something that now impacts on their functioning, and we can see that from something as simple as somebody that dresses well is now dressing very dirty. Somebody that greets people is now not talking to people. Somebody that has a good relationship with their wives is now beating their wives. Now that deviation that is now affecting those functions in terms of personal, family, occupational, and then communal functioning. When there is that, then we should have a discussion with that person to first understand if they've noticed that change in their behavior. Now, if they now notice, now ask for explanation from them or from people around them, because sometimes you might not be able to confront that individual, and it might just be that you are only able to confront, to talk to somebody close to them, like their wives, or like their wife, most especially in our community, or like their partner, or if it's at workplace, like their bosses, who might be able to talk to them better than you, or the supervisor at work. Now, that would be something that one could do. And then once they talk to them, then they can approach any psychiatric facility or tertiary institution that might not even be a standalone psychiatric facility, especially because of the stigma in our society. Yeah? There are tertiary institutions where we have a unit that is a mental health unit, and then you can speak to someone about it. And these days, we're also making advocacy for religious leaders to now also be in to work with us now. So they work with us a lot, in which, because a lot of these people often go to them before they come to the psychiatrist. And so religious leaders now know the signs to look out for, to see when there has been a change that is persistent and is affecting functioning. And then they can refer to the tertiary institution or to the doctor, who might then now refer to the specialist to treat. That's what I would say.
Yeah, and you're so right in terms of the partnership that we have going on. I think a lot of people are really not aware, and I think that we can do a lot more in terms of partnership with religious leaders and letting them be aware of when to refer, because we also need that level of pastoral care, whether for any religion. And one thing that we can really take away from today is just go to a physical health hospital. I mean, sometimes we also know, and I don't know for you, Dr. Kilani, but I'm sure that there are a lot of cases where people present with mental health difficulties, don't make assumptions, and we've referred back to a physical health and said, this is physical health, this is not mental health. But imagine if that person has been taken from pillar to post and thinking, oh, it's a mental health disorder, when it's really a physical health that would be treated, and that would be the end of it, because we can have presentations like that. So if you're worried, Dr. Kalani has mentioned so many things that we can see. The first thing is go to a normal hospital. Let's even start from there. Whatever it is, the person will be referred to the appropriate place for care. That's the first thing. I think I just want you to wrap up on the role of spirituality even in care, because you've talked about so many things, and how even with culture shift, and I do believe that even in Nigeria, without culture shift, people are using medication and they're still seeking care. That's why in a lot of hospitals, even if it is surgery, even if it is a cesarean section, for physical health difficulties, we still believe in the role of spirituality. With the way that CS is now done like pure water today, we still believe that it is a journey and it is a spiritual journey that God has to see somebody through, or any religion or any belief. What's the role of spirituality in treatment? Do we now say, oh, this is not spiritual, or is there a way we can integrate spirituality into treatment?
Okay, thank you very much for that very significant question, because spirituality is not going nowhere. As a matter of fact, there is a drive now for spirituality, even in the Western world. Now, people, so it's just like fashion. So people are going back to spirituality. And I will give an example. In psychiatry, most of the psychotherapy that we do now, the CBT, the mindfulness, they are based on Hindu spirituality, spirituality-based concept. A lot of them, mindfulness, yoga that people now do, they are all things that are based on the Eastern religion, Eastern spirituality. Now, spirituality evidence have shown, and these are radio imaging evidence that have shown that individuals who are spiritual actually have better resilience than those who are not. And it's been shown that with radio imaging evidence that when people have psychotherapy, the same changes that we see are similar to the changes that we see in spirituality. And a lot of our spiritual leaders are actually untrained, unstructured psychologists. And we know psychology is evidence-based treatment. So we're just coming back to what has always been around. It's just that we want them to now have more training. And there's also a concept called culture brokers, in which we take the spiritual leaders as partners, because a lot of times you want your patient to be insightful to take your medication. You don't even need your patient to believe that the illness is being caused by, some chemicals in the brain, dopamine. No. The patient does not want to understand that. The patient wants to understand that this medication I'm taking will work. And if the pastor, the malam, tells them, just say in Jesus' name, or say Bismillah, or say an Hindu word and take the medications, it will work. They would take it. That's one. And secondly, is the issue of resilience. Spirituality helps with resilience because it helps with that cognitive framework of the fact that so that transcendental relationship has to do with the fact that, just like Freud said, that you've put all of your problems, all of your challenges to a superior being whom you think is bold enough and strong enough to help you. Once you do that, it's just like purgatory in Catholicism, in which the mafia back in the days, even when they've murdered people and then they go to purgatory, they feel fine the next day, they can go around doing their thing. So, and that's just the reality of having spirituality. You have a communication with a higher being whom, when you think you've gotten to your wit end, you can then hand over all of this to them. And again, I'll have to apologize for the technical issues we had at the early stage of this presentation. I'm sorry.
No apologies, Dr. Kilani. Just £10. That's fine. But honestly,
spending the past.
No, £10. I'll accept pounds.
even despite the technical error, I think we've had a very robust conversation, and we're able to find that balance that it's not black and white, and there is gray area when it comes to karma, spiritual attack, and psychosis. And more importantly, I believe that some of us here are better in terms of knowing what psychosis is, what are the symptoms of psychosis, how does psychosis present, and even differentiating it from experiences that we have. I don't know if there's anybody here who've ever heard their name being called. Maybe you're in the room, you heard your name being called, and then you step out to the living room and you're like, did you call me? And they're like, no, we didn't call you. That is the experience of somebody who is hallucinating. Now multiply that by 1,000. So these are real experiences. This is distressing experiences that happen to people. And imagine if you're hearing your name being called 1,000 times in 5 minutes. How can you do anything? There is no way it will not impact the person's functioning. Why would you not start believing that somebody is trying to harm you because you are hearing all of these voices? So you just have this ripple effect. And one thing we know is that time is very important in treatment. Just like, if you have physical health problem, you have headache, you're sick, you have temperature, you need to seek help early. The same thing goes for mental health difficulties. The same thing goes for psychosis. Time is very important. Thank you everybody for joining. We are really, really grateful that you're able to spend your evening with us to have this conversation. Thank you so much, Dr. Kilani, for, honoring our invitation, preparing and giving us all of this knowledge about spirituality and psychosis. We're really grateful to have everyone here. Please take the time to fill the feedback form. We would really appreciate it. We are so grateful to have you here. We have